Welcome to the NeoFOCUS-UK Education Group webinar series.
I've just quickly introduced myself and I'll let Sarah introduce herself. So my name's Liam Mahoney. I'm one of the consultant neonatologists at St Michael's in Bristol. I'll hand over to Sarah quickly. You can introduce herself.
And hi, I'm Sarah. I'm one of the neonatal trainees that's in St Michael's as well. I'm currently on fellowship with a focus on ultrasound this year.
Thanks, Sarah. What we thought is we would share our experience, because this is relatively new for us in Bristol, to have a fellowship in St Michael's for point of care ultrasound. So I'll just quickly start our presentation off. So me and Sarah both be chatting about this a bit, and I'll just quickly share my screen. So if someone could tell me in a second that they can see these slides, that would be amazing. Is it all right if someone just shouts out that they can see them?
Yeah, Liam, you're good.
Grand. All right. So yeah, thanks, Harsha. Thanks, NeoFOCUS Group, for this opportunity to present our experience about developing a point of care ultrasound fellowship here at Bristol, and we want to share how we went about it, the problems that we've kind of faced with it, just our experiences of other people who are looking to develop this as well in their own units. And Sarah's going to present some of the impact that it's had, because it's made a real palpable difference with the care of patients on the unit. So I suppose the outline of this talk, what we wanted to go through is talk a bit about what was our kind of local drivers. Why did we want to do this? It's not because, a few of us were interested in point of care ultrasound. What was the clinical reasons why we wanted to do it? A bit about the fellowship and a bit about how we created the job, because I suppose that's one of the important things, is that with this is how to actually practically go about creating a job plan and how to get it funded in some way, which I can say one of my colleagues has done most of the work behind that. Talk about its program and its development, how we've created a governance system around the point of care ultrasound that we want to focus on, and how it's aimed to be sustainable. So this isn't something that we want to continue beyond Sarah, who's done an amazing amount of work with this. And then Sarah will go on to chat about the clinical impact it's had, and also about how it helped her as a trainee. So I'm going to briefly just talk about point of care ultrasound, so where we were and where we are. And I suppose we all probably know this from being on multiple different presentations, that point of care ultrasound has been back as far sort of as the 70s, really, when the first sort of bedside cranial ultrasound was kind of created, through to the late 80s and 90s, where it really took off in A&E in particular with the development of the fast scan. We've then had the neonatologist performed echocardiography statement, which has come through back in 2011, through to kind of the ISNIC POCUS statement, which was back in 2020 with Yoga and Singh, etc. Really kind of brought it to the fore. And again, we don't need to. Oh, someone's got their mic on. Could everyone just check their mics? Just because I can hear an echo. Is that all right? Sorry. I suppose with point of care ultrasound, we've seen significant increases in its use. Not only traditionally, we've all used it for cranial ultrasound, but lung, cardiac, abdominal, and line. And this, I suppose, one of the things to pointing out was this really, which was the first framework about how to use POCUS, and it's kind of what we based what we got developed my interest in trying to create it within the neonatal unit as well. So I suppose giving it all a bit of a context, really, what are we and why did we want it at St Michael's in Bristol? And I suppose we are quite a specialist centre in that we admit for neonatal surgery, including neurosurgery. I think we do every kind of surgery bar transplant, and we're not a liver unit, but we do everything else bar that. And we're a massive, referral centre for the southwest of England and southwest, and sometimes further afield, with quite a high acuity, with 31 cots, really, with babies with all sorts of congenital anomalies, where having access to point of care ultrasound really can make a big difference. And I suppose, why do we need it? Well, often, I suppose, going back to the definition that it's not a replacement for a specialist, imaging by a radiologist, but I suppose one of the things is that it is an adjunct to asking a specific clinical question. And with the patient population that we have, which can often involve lots of congenital anomalies, lots of cases where the diagnosis isn't necessarily clear. We have an awful lot of lung pathology, including, pleural effusions, etc., which actually lends itself quite well to having a rigorous POCUS program to try and enhance the care that we give to the children that we have on the neonatal unit. But I suppose it's having that boundary where we're making sure that it is staying within POCUS and not crossing over to a formal departmental ultrasound, which is something that we're conscious of. And I suppose, again, some of the things which really brought up why we wanted to develop POCUS was the emergence of the various different publications within the literature, and how that's just gone up exponentially over the past number of years. And I've got 3 specific publications which kind of had turned my head and made me think about that this is something that we needed to do. And one of them is done relatively, some time ago, back in 2013, by Cafarero et al. In San Diego, where they looked at the results of PICC line placement under ultrasound guidance with standard practice. Now, I'll allude to this later on in a couple of other slides, but St Michael's is a standalone hospital, albeit we're very close to the Bristol Royal Infirmary and the Children's Hospital. In fact, we're probably about 200 yards away. We're up a massive hill, and actually that does create logistical difficulties in timings of scans. We have lots of vulnerable babies, and actually this particular study showed that if you used ultrasound with PICC lines, the likelihood of, one, getting it in the right place, but also reducing the amount of manipulations and X-ray exposure, was much better with point-of-care ultrasound. And there was a similar publication in Taiwan looking at the use of ultrasound-guided insertions of UVCs. And similar reasons for having sort of not easy access to radiography. Although they do come as quickly as they can, it might not be as quick as we necessarily want it. But also, I suppose, one of the emergencies is just how, sensitive and specific point-of-care ultrasound with regard to lung ultrasound is about different pathologies, and how it can change kind of management, or how it can, exclude the need for an X-ray if you're doing multiple sort of point-of-care ultrasounds looking at the lungs in certain diagnoses, which can again help the care of those infants. So I suppose this is our picture of St Michael's, and these are our radiographers, and well, not radiographers, our various colleagues who often take quite a fair bit of time to come up the hill, and probably a fair shorter period of time going back down the hill. But this is just one of the reasons why POCUS in Bristol is kind of really important. I've mentioned the hill, so actually getting people up the hill in a timely manner can sometimes has logistical difficulties. It's not through what people's want to do it. It's just we're not co-located with another hospital. So actually having another skill and another imaging modality that doesn't depend on external departments coming to our hospital is helpful. It has a really good evidence base. And can help with in addition to timely X-rays. We've also found that perhaps it might help with our worries around commencement of TPN. We've done multiple audits in the past, finding that often the stumbling block we have for starting TPN early in our extreme premature babies has been being able to get X-rays and being able to get lines, not necessarily reviewed, but lines in a acceptable position in a timely manner. But also, there have been, going back to, I suppose, the publication which showed the different specificities and sensitivities, being able to use lung ultrasound and being able to have a good governance structure around that to look at effusions and pneumothoraces, etc., will only improve our diagnostic yield and our patient safety as well. And I suppose one of the things, and this is not to say that any of my colleagues who were there before, and myself and a couple of other colleagues started, but there was I think probably what happened is over the past number of years, we've had new consultants come on board who have particular interests in line and lung POCUS as well. And I feel like we've actually hit a critical mass where we've got enough consultants and people who are on service. That means that near enough every shift. Probably if someone wanted to get a scan of this nature, there would be someone around to do it. I've highlighted echocardiography, but that's for another day. And I suppose I'm now going to move on to a bit about how with this, move a bit away from about why we want to do it, a bit about how we did it. And I suppose one of the biggest things that we've been asked is about how we've actually employed someone who is taking a substantial amount of their clinical training, is dedicated to creating a point of care ultrasound fellowship. And kudos goes to my clinical director, who's Adam Smith Collins, who we have 3 of these fellows at the moment. So they are advanced clinical fellows. And part of the reason they came into fruition within St Michael's is these kind of arrangements that we have. So using what's been happening with training and what's been happening around service requirements to our advantage to build cases for these particular jobs. Now, these jobs are whole-time, well, they can be whole-time equivalent, but they're most of the trainees who are in them at the moment are 80%, but a certain percentage of that job is taken out. So 20%, for example, so the whole-time equivalent trainee who's 100%, 20% of their time would be dedicated to either research, teaching, or a significant QI project. So that's where Sarah is at the moment, in that she has dedicated time for a QI project. It's aimed at higher specialist trainees, grid trainees, spin trainees who are in the latter parts of their training, because actually the predominant amount of service provision is based for ITU or out of hours, so that's it's not necessarily rounded to having equal number of shares on postnatal ward or high dependency. It's very much aimed at delivering the on-call service, so that's been helpful and quite attractive for post holders as well, who maybe want to refine those areas of advanced ITU skills but prior to CCTing. But also we've used things from the BAPM guidance about optimal arrangements of intensive care units, using that framework for practice to back up our need to have more tier 2s on the rota, but also Progress Plus, which has made significant changes to our tier 1 roster. But actually, whilst looking at those initially and feeling like we were losing trainees, being able to actually use that and build that into sort of business cases, but also these proposals in order to get trainees and develop these posts and get people into these posts in order to not only fulfill up our rota, but also provide opportunities for people who want to take on, have a significant part of their job where they can take on a significant project. And that's where it bore out with Sarah, really. I've known Sarah for quite a long time. I've been a registrar. She was an SHO when I was a registrar, so we trained together, and then latterly been a consultant, and she's been a grid trainee with us. And so being able to use this job plan and being able to create around that, we were able to then therefore think about and develop a fellowship program. And using that, we not only had that job in place, we needed to look around to see how to perhaps go about looking at a framework for developing such a job and developing such a fellowship, so that not only did Sarah get the most out of it, but there was something that was sustainable, that would be a legacy that she would leave after, that actually when Sarah developed this program, with the various consultants and team that are helping her, that there'd be something sustainable and a program in place that meant that it was something that was ongoing for other trainees to do and other trainees to develop their skills. And so most of these publications come from people from the NeoFOCUS group, not only the SLURP study, but looking at kind of elements of the neonatologist performed echocardiography publication that was in infant, looking at the lung ultrasound publication and the framework for practice, and taking elements of those and applying them to this fellowship. And so then Sarah and I really sat down and actually went through about look at the different objectives and how the fellowship would actually run, and what were the bits that we are focused on. Because actually, whilst POCUS is massive, we've got lung, line, cardiac, etc. We wanted to develop something initially that would focus on an area where we felt we would really need POCUS. And the two areas I suppose we really focused on, alluding back to those publications, was about lung ultrasound and also line ultrasound, because those were the two areas where we felt that actually in St Michael's, they would make a very big difference in terms of point of care ultrasound and having the skills within the department to perform them really well. And also have good availability of them, because areas such as abdo ultrasound, echocardiography, and cardiac POCUS, so cardiac POCUS and abdo POCUS. I think in terms of if we have an abdominal question, we'd run that with conjunction with the surgeons, and generally would need a departmental radiological scan. I suppose echocardiography, we also have the benefits of paediatric cardiologists, but we also have a separate neonatologist performed echocardiography kind of program, which is up and running. But we felt that actually that needed to run differently to what the POCUS program would be. So very much focusing on just line and lung ultrasound at this point as being areas of POCUS to focus on. That something more could hopefully develop out from. I'm not going to run through these documents, as you can read them yourself, and we'd be happy to kind of forward them on to people. But you can see that we were quite rigorous in terms of what we thought we needed to go through. And, in background to this, we had Gantt charts outlining the timeframes that we wanted these things to be put in place, and when we wanted things to get, when we wanted sort of to achieve certain milestones. And we felt that all of this was kind of necessary to make the program sustainable. There goes on to things such as technical aspects, so such as having the machine set up for lung and line ultrasound, making sure that it was maintained, made sure we had things like pre-populating labels so that when people did it, if we were asking people, which we do, to do 6 areas on a lung ultrasound, that we have pre-populated labels that people use, so that when we do the ultrasound, they're done in the same way every time, so that when we come to review them, same way in probably how cranial ultrasounds are carried out in all units in the country, we know what images we're looking at, where and when, and that they're going to be done in a sequential sequence. We did realise that we needed a new machine, and I'm pleased to say our clinical director has managed to work some end-of-year financial magic, and we've actually got a new machine being delivered, I think it's actually today, which is amazing to help facilitate that, because our machine probably wasn't fit for true point of care ultrasound in there. It would take the best part of sort of 5-10 minutes to load up. I suppose the other thing to lead on to that is not only the technical aspects, but also the governance aspect of this. Now, we're lucky in that we have EPR systems, and that within that we can create our own forms. And so actually we've created forms which not only satisfy the needs of the NeoFOCUS lung ultrasound template, but also the CACTAS accreditation, which is live at the moment. So people can start doing these scans for logbook purposes, but also have these as logbooks, so they're not having to, so they're in a patient confidential EPR system. But if someone needed to go back to prove how many scans they had, that this EPR system actually creates a logbook for them of all the scans that they've done. So actually it makes the purposes of keeping a logbook easy for the person who's doing it, easy for their accreditation, but also from a governance structure actually keeps, from an information governance point of view, keeps it within that EPR system. So actually we know that someone's not walking around with sort of A4 bits of paper with patient details on. And just to give an example, we use the Philips ICCA system, and this is kind of this is actually the template of the logbook that we of the lung ultrasound form that we have that Sarah created. And each of these tabs open up to talk about A lines, B lines, whether you have consolidation, whether you have a pleural effusion, whether you have, and goes down to details such as dynamic or static air bronchograms, but all of them are in drop-down boxes. So actually they become pre-populated. So it's quite easy for and intuitive for the person to do it and to go through this form. And so it just takes away it, and also it makes the reporting standardized as well, which is one of the things that we felt needed to be done as well. This is an example of how of when it does go through the drop-down menu of the various options that we have, and within that, whenever you click on one of these boxes here, it will take you through various different other options. So, for example, with A lines, it would say yes or no. For B lines, it will say no B lines 1 to 3, 3 to greater than 3. confluent or consolidation. So trying to follow guidance that you've got out there. So for example, if you're trying to create lung ultrasound scores, then it makes the lung ultrasound scoring easy as well. Moving on to the other part of POCUS, which you did, which is line POCUS. We've again a simplified form for that, and one of the particularly focuses, because we're using and Sarah presents some data on UVCs. This form is particularly focused on UVCs. At the moment, we don't have enough people, I'd say, within the department to use ultrasound to look at long line position, but we've got definitely a majority of people trained up to look for adequate UVC position. That this form at the moment is deliberately focused on people visualizing a UVC and being confident on where its final position is. So I suppose, carrying on the theme of governance, behind this we've had to create guidance, and if people want to see that guidance, we'd be happy to share that. And also, from that, we've had to create, from our safety and governance team, we've been asked to actually create SOPs, so that when people are doing POCUS or they're doing UVC inserted, ultrasound inserted UVCs, that we have SOPs of how we do that. We're lucky in the sense that we've had no issues from a radiology point of view. In terms of storage of scans, our ultrasound machine automatically uploads it to the patient record without having to go through CRIS, which we're quite lucky for. And our involvement with radiology has been relatively nuanced, because we do this sometimes anyway in terms of cranial ultrasound scans, in that they don't look at them. They just get stored in the same system and we report them locally. And that's what we're kind of trying to do with our POCUS remit. But at the same time, we're very conscious that we want to keep our radiology colleagues on board and that they're happy what we're doing, because we want to keep within that boundary that this is point of care ultrasound and is not merging over to the radiologists, and is not a replacement for the formal scan that they will do. We have had actually some compliments from radiology, which is great, about lung ultrasound, in that when a baby had when we felt that a baby probably needed a formal radiology scan, they came along to do it. And actually they looked at our pictures and they weren't sure that they were going to get better pictures than us. So that was always nice to hear, that actually our skills are recognised by our radiology colleagues. So I suppose the biggest part, one of the things that we were quite keen on, is that we wanted people to demonstrate that they were at a level, or be able to demonstrate that they were at a level that we were happy with their competencies. And so at the moment, we are very much using the lung cactus accreditation through the Institute, through the Intensive Care Society, which is endorsed by the Royal College of Paediatricians and also the Paediatric Critical Care Society as well. So we're using the cactus framework at the moment. So we hope to eventually move to NeoFOCUS when accreditation hopefully becomes available. But one of the things that's been really good with that, and apart from our internal governance structure, is that Cactus, our local cactus mentor, actually is based in Cornwall. So she's actually an adult ITU consultant, but every week on a Tuesday, she will host a meeting, a regional cactus meeting, where people from different specialties, and at the moment, we have people from PICU, we have about 3 or 4 of us sometimes from neonates, and a smattering of ITU, adult ITU trainees, presenting lung ultrasound and echoes and other ultrasounds at this meeting every week, which has been really good, not only for peer review purposes for accreditation, but also I think one of the joys about lung ultrasound is that it crosses different specialties. And so I think from neonates, we've really learnt a lot from the adult ITU team about diaphragmatic excursion and using different probes to look at diaphragmatic excursion in babies, to see how that may help in terms of our ventilation strategies with infants, and similarly, being able to show some of our scans, and the clarity of scans that we get in comparison to some of the adult trainees has really helped them. And so that's been a really useful thing for our learning, but also, as part of our governance structure, so that we're keeping up with our CPD with regards to lung ultrasound. Line ultrasound is a bit different, and I'm just going to quickly have a look at the next slide. And Sarah, I just wondered if you wanted to take over here and talk a bit more about this, because you've been absolutely you know, you've created this is your baby here. So I just wonder whether if I carried on moving the slides, and if you wanted to just talk a bit more about it, if that's okay.
Yeah, that sounds good, Liam. Thanks. So yeah, hi everybody. I'll just talk a little bit through some of our governance around the line ultrasound. You can go on to the next slide, Liam. So I've looked at all sorts of guidelines that other people have put together internationally as well. And over the years, I've been to lots of online YouTube videos done by different hemodynamic teams, the NeoFOCUS team, and then the international collaboratives as well. And I actually joined a talk from Melbourne years back when I was in a district general hospital, and this image is actually from them about how they went through their processes. I think they were the sort of starting force behind using ultrasound for UVCs, and that image is actually from them. So we sort of helped from all of this, got our governance together about how we were going to do this in the most safest way, essentially. And this is just to show that we do it in an aseptic way. And this is part from our guideline about how we do a 2-person technique and how we go through that in a step-by-step manner. You can go to the next slide. We have developed, and I'll show you on the next slide as well, a full educational package online that we get all of our trainees and nurse practitioners to go through, and anybody who wants to be doing this as part of our accreditation, a little bit like the cactus for the lung. So they just get some background information. They also come to educational sessions that we host, and they get a face-to-face hands-on session, and actually multiple hands-on sessions whenever we have UVCs available. We come in and show them how to do it until they feel confident to do it alone. This image is just really from Kishigami's paper. I'm not sure if I'm saying that right, but hopefully I am, about how they use compression to straighten up the ductus venosus and aid manipulation of the lining. And that is our focus actually here in St Michael's, getting our lines into position rather than doing line tip assessments. If we go to the next slide. This is just to show the module that I've created. So in the Southwest, we have a deanery-wide, a regional-wide platform called Peds Hub that is run by the pediatric teams, basically, and they've allowed us to host our module on there, but it's only accessible if we grant access. It's now gone live for our team, and this is a module that I built that is interactive, essentially, and I think rightly called the plight of the UVC, but it goes through understanding ultrasound, understanding the umbilical venous anatomy, a little bit about our equipment, but specifics around different modes that we use and probes that we use, our protocol tips, and particularly pitfalls of ultrasound, and then how we document this all. And then there's a little quiz at the end, and then they can give some feedback about how they feel about this module. I won't obviously go through it all in detail. Liam, you can go through. I think Liam's basically spoken about this, but as well as the external peer review meetings that we go to from a lung ultrasound point of view, Liam and I host internal meetings twice a month. Pretty much we do one each a month, and that's to go through either education and introducing the team to what we're doing, or to review the scans that have happened on babies over the last couple of weeks. And it's been very, very successful in terms of trainees coming and enjoying and learning. But it also brings lots of conversation and learning about what might have gone wrong or not worked, or any feedback that they feel from a procedural point of view is not going well. And yeah, as I said, all of our team are going through the module at the moment. Liam?
So I suppose one of the things that I've alluded to is that we want to make this sustainable. And so, you know, until other accreditations come on board, you know, a couple of us will become Cactus mentors at the moment. And actually, we've got multiple trainees and consultants actually going through this mentorship. You know, our guidance has been ratified, and it's probably going to be accepted by the trust imminently. I've spoken about the new ultrasound machine and actually the ability to get a portable probe as well, hopefully. But one of the things that's kind of helping us make this sustainable is actually, whilst we're on an island at St Michael's respectively, and that we're in a different hospital to PICU and things like that, actually our weekly meetings where we've met with PICU, where the PICU team down the road actually join on that meeting, has developed collaborations in the sense that we've looked at how we can look at how we develop the POCUS program within the trust with the PICU team, and actually we've met with the adult ITU team actually to look at how there might be ways which are the similar issues that we have with how to develop this program and how to, again, to make it sustainable. So things such as looking at how we've done lung ultrasound forms and seeing whether it's fit for purpose for all three sort of areas, or certainly for us and PICU, has been useful, and develop those collaborations. Certainly, I suppose having someone, having two people on the ground and one of the registrars, Sarah being the force behind this, has really made that it's become now an integrated part of practice, where people who don't perform point of care ultrasound, but actually are seeing the benefits and are requesting that people do it for them now, is now becoming commonplace. And that's fantastic. And needless to say, none of this would have been possible without Sarah. And our realization within the consultant body, there was a comment about, well, we need to find another one of Sarah to keep this going, definitely. But certainly, I think she's going to be leaving a legacy where this is going to be sustained. I think, Sarah, I might just quickly, I'm going to brush over this because Sarah's going to bring on to more about the UVC data later on, but talking about our kind of what it's had on our kind of success rate for UVCs. And I'm going to go through a couple of cases where it's kind of made a real difference. And so this is an ultrasound, and I apologize for I've had to take this on my iPhone because I can't actually on our, I must admit, I will say that the family have consented us to use these images for this, but also publication as well, should we want to, is that this is a baby that came from another hospital who was handed over to us by the transport team to say that they had a big pleural effusion on one side and that their ventilation was particularly difficult. They were thought to maybe have a congenital lung lesion, but they were born at 30 weeks in an outside hospital that needed increasing amounts of FiO2 and were looking quite precarious from a respiratory point of view. And so, as well as getting an X-ray, which I'll show later on, we got I've probably done it the wrong way around. I should have showed the X-ray and then showed this, but we did a lung ultrasound quite early on. And for what we could see, and is actually quite big area of lung, which looked quite hepaticized actually. But one of the things that was interesting was that just behind it is that we could see this area of relatively aerated lung, as well as a small pleural effusion. But the colleague that handed the baby over had said that if this baby's respiratory status gets any worse, I think there might be a pleural effusion on the X-ray, put a chest drain in. So we did this, and we actually saw that the lung, that tissue parenchyma that was there, was looking extremely odd. There was a small pleural effusion. This is quite a big baby, so that pleural effusion is probably about 1 centimetre at its depth, at its biggest depth that we could find. But also that there was a big sort of what looked like a massive parenchyma, some parenchyma of some sort, which was odd looking. But there was definitely some healthy lung, aerated lung hiding behind it that we needed to try and improve the aeration of. And when we put the colour flow Doppler on this mass, it lit up. And it's not, again, the best picture, but it sort of made us, again, very nervous about putting, whilst the X-ray looked like there could have been there is a pleural effusion clearly, but whilst there was a pleural effusion which could be improved by a chest drain, but seeing this and how vascular this mass was, it kind of made us quite pleased that we stuck on a probe and not sort of gone with putting in a chest drain, because we were wondering if we did prang this, whatever this mass was at the time, we could get ourselves into quite a bit of quite a sticky situation. And actually, latterly, this is a lung ultrasound that we did later on, is that what we found, this is with a curvilinear probe, relatively low frequency. This is basically the whole chest cavity of this 30-week infant, is that we were able to image kind of at a latter date. And one of the things, this is probably the wrong scan to prove, it's not the wrong scan. We should have started simple and gone complex, but this is one of the more complicated scans that we've done. But here we could see the pulsatile aorta, which we knew as the aorta because it had a UAC running through it, but also the vertebra. But what we could see was actually a feeding vessel. We could follow that feeding vessel coming up from the aorta, going into this huge mass of tissue. And actually, it kind of then made us think, well, actually, this is a huge mass of tissue which has had a feeding vessel from the aorta. It's likely to be a sequestration. We were able to get a CT scan relatively early of this baby. And actually what we could see from, we knew that we had that scan on day 1. And then at about day 8 is when we got the CT scan. But we knew from day sort of number of days beforehand that this was probably a sequestration. And as you can see here on this cross-sectional image, is that you can see a vessel, a huge vessel coming off the aorta here, feeding this lung mass here. And on this reconstruction, again, you could see the quite big feeding vessels coming off the aorta. So I suppose one of the things about safety, and this might not be the best example because it's quite an extreme example, but I suppose one of the things it just proved to me about the extra imaging modality and how it's actually quite quick, and how actually putting a chest drain in with this baby could have been potentially quite, it could have led to complications. But if we had just had the X-ray, it would have been a completely reasonable thing to have done to improve this baby's respiratory status. And this was actually the X-ray that we initially got actually from that baby when they came transferred. So I probably should have put this at the start, where so you can see on the right-hand side, looking at that, you would think that there's quite a big, pleural effusion. But having had that ultrasound images from beforehand, it made you think about twice about putting in a drain. And actually, that pleural effusion got better without any treatment. I suppose this is the example of the other area of POCUS that we're focusing on, which is lines. And as you can see, this is actually the same baby who came to us with a UVC, which they thought was low lying. And as you can see, the UVC here is in one of the hepatic veins. It's going off. It's missing the portal venous, the portal sinus. So Sarah and I, who were actually on call that night and were therefore able to use the lung ultrasound skills to then sort of compress the liver, pull that UVC out in a sterile manner and put a new one in. And we were able to actually get the UVC just that the tip is just here. You can see this drop out here where the tip is here within the portal sinus. And then with compression, we were then subsequently able to push the line, obviously, and get it into the right atrium and then bring it back to what we thought was a satisfactory position. So just showing this again, you're putting it with compression, with the ultrasound, we were able to straighten out that pathway and then make that UVC and be confident that we were getting it into a good position. And so that's an example in one patient where point of care ultrasound has made two massive differences. I suppose point of care ultrasound there are well documented and well publicized kind of protocols for the crashing infant, and this next few images, I have to acknowledge my colleague Katie Hunt, who not only managed this baby superbly, but also used her point of care ultrasound skills to make a massive difference in this infant. So this was a baby that was just having some TPN in the HDU of our units, long line in an acceptable position, looking well, that then suddenly collapsed in a heap, in a respiratory collapse. Then she got this X-ray, and she really wasn't sure what was going on with this baby who just suddenly collapsed in a heap. But she puts the lung ultrasound on as part of kind of the SAFE-R protocol, which we sometimes use on the neonatal unit in babies who become very unwell quickly. And what she found immediately was that there was quite a huge pleural effusion, which was complex in nature. As you can see there, it looks almost a bit like a snowstorm. But the next few images, I think, worried her even further, in the sense that that was the right lung, but this was the left lung. And she thought she could see maybe this was thymus or very squished lung, but what was happening here, in that she then focused on a bit further down and then realized that the lung was completely compressed up here on the left-hand side. And this was a pericardial effusion, and this was the heart beating away there. And so a prompt call to our cardiology colleagues who placed in a pericardial drain. And we actually got TPN out of this baby's chest and also pericardial space, which has all made us a bit more nervous about putting in long lines, because we've had a couple of babies subsequently who've had lines in the upper extremity where we've had sort of TPN within the chest cavity or within the pericardial cavity. But having the point of care lung ultrasound, and also, while she doesn't perform kind of echoes, she has the understanding and the skills that she's built up from her point of care ultrasound skills, that she can find, life-threatening pathology quickly, which she did here in a very prompt fashion, and the baby was treated and made a very, very good recovery. I'm going to hand back over to Sarah, if that's okay, because I suppose we're going to spend the last sort of 5-10 minutes just talking about the impact it's had on the trainee.
Thanks, Liam, and yeah, thanks for letting me have a little chat at this point. Liam, I'm just getting a bit of feedback, if you don't mind. Just silencing. So hi everyone. So I just thought I would talk about 3 aspects of how it's impacted both me, the department, and the patient really. And so first of all, these are my children, and I put them on there, one, because I like showing how cute they are, but I will caveat that with I often enjoy coming into ITU as a bit of a break from them. But whilst I was off on parental leave with Jack, my youngest, is when we started sort of creating this space for me to be a POCUS fellow. And it took a year of preparation before, and then a good 6 months of pre-preparation to hit the ground running before I actually came into sort of a paid post and back at St Michael's. But yeah, they are my children. I'll talk a little bit more about how it's impacted me as a trainee in a second, and then also the department and the children. So oh yeah, Liam, if you go to the next one, that's great. I thought I was changing it then for a second. So I think ultimately I wanted to sort of say that I feel great as a trainee. I think this post, as Liam said, I'm 80%, 20% of my time I just get to focus on my POCUS work, and it is very vast, and it is a huge amount of work because we are trying to do, our mission statement is around the safety and the governance and a slow, appropriate, educated rollout of the work that we are doing. And I've been very rigorous and trying to ensure that, but it's given me so much autonomy. The team have been absolutely fantastic in trusting me, but also supporting me from an educational point of view in all aspects. I have done a huge amount of QI methodology, which I have done before, including the Gantt charts and the fishbone analysis to think about how we are going to roll this out and all of the different barriers that we may face. And so I feel from a management point of view that I've built a huge amount of skills. I've been able to, as I showed you, build educational packages. I've worked with the tech teams to build reports, and I've done a lot of teaching for the team, both face-to-face and then in seminars. I've put complex physics. I have not taught anybody on complex physics. I've done basic physics in complex cases, I would say. As Liam said, it's a huge amount of collaboration. We want this to be sustained, but we're working very closely with radiology and our PICU teams as well, so that we can do this in a governance way. We've been writing business cases. Actually, we've been writing charity funding cases, and actually we've been able to get the new ultrasound machine through last minute money that's come in the trust, which has been helpful. And I've just learned skills myself through my own accreditation. So I definitely promote an advanced fellowship for anybody who's thinking about it. It's also incredibly fortunate for me as a parent to be able to stay local, to do something like this, and build that side aspect to my career and my future. And I'm post CCT fellowship planning now to continue either in POCUS or hemodynamics. Next slide, Liam. I think from a department benefit point of view, we sort of alluded a little bit to how St Michael's works in the Hill, but I think some of our work, and we're getting data that's showing this, is helping with our patient flow. We have a huge educational team that's behind this with a specialist interest group now, and it enables us to provide very attentive training to the team that are on the shop floor. And I think we're helping drive others' autonomy and innovation on the unit as well. That's not just I won't take just credit from that for myself. That Liam drives a lot of that as well, but it's our whole consultant body. But I think we're definitely adding to that. One of our advanced nurse practitioners has now become our lead for POCUS too, particularly for the UVC work that I'm doing. That's part of the sustainability of it. There is a next me, it's not me, but the next fellow that's coming that is definitely needed, who's lined up ready to take over from September, which is really, really vital. It's been really nice that our previous 6 months, we've had some tier 1 paediatric trainees who have assured me that they will not be convinced by PDD that they will not be a neonatologist. They said they're very much planning to continue their career in neonatology. And I think that is partly due to the educational work that's been happening by myself and the wider team, not just me, the hugely wider team, about the enjoyment they've had with our team. And this is I've done a lot of work with the nurses as well. It's an MDT education, and I think they're getting a lot of enjoyment from it because of the patient benefits, which I'll go into. 60% of my time and the other advanced fellows, we are clinical, and we're particularly in ITU, and it's been built in that can then enable us to cover gaps, but also enable the other trainees to have time for their supported professional activities. And the feedback I've had from them is it's really helping. Liam. So yeah, I wanted to get quickly onto the patient benefits. So I'm just going to talk about the umbilical aims initially. So we wanted to increase our success of umbilical venous catheters being in the correct position on first try by 20%. We wanted to reduce our time to TPN, and we wanted to reduce the number of x-rays we were having to do, and of course focus on safety and governance. Liam, next slide. So before I came with another colleague, we had a look at the UVC data, just how successful we were and how often we needed to adjust. So there was 48 UVCs done in the 6 months prior to starting this program, and the success rate of the UVCs going in was 52%. Of that 52%, 64% needed then adjusting and re-x-raying. There were a couple of babies, I think 3, that all had repetitive attempts at the UVCs, not under ultrasound guidances or before ultrasound, and none of them were successful, always took the same path. And our time to TPN, NICE guidance saying should be within 6 hours, BAPN as soon as possible. Ours was about 9 hours and 41 minutes in that previous 6 months, and it was worse if we failed the UVC, obviously for our preterm babies, because they then needed long lines, etc. That was just in our UVC babies. Liam, if you press next, it should show my post-implementation data. Excellent. So post-implementation, as probably most people, we don't do a huge number of UVCs. The total number of UVCs we've done in the last 6 months has been 36, so slightly less than the previous 6 months. But of those 36, we've done 14 under ultrasound guidance. I think I've supported all of them, but I've probably done 90% of them myself. Our success rate is 86% at getting in. So we've increased our success, which I'm very pleased about. Each time we've put it under ultrasound guidance, it's in the right position. We haven't needed to adjust. And we have had success in taking lines out. As Liam showed you, the one that was from out of region, we took one line out and we put it back into the correct position under manipulation, which was great for a tertiary centre where babies come from other regions. We are getting faster at getting our TPN in, which we're really pleased about. It's almost 5 hours, but that was since the beginning of the 6 months. I think we're getting quicker just because of our knowledge around that as well. And the actual ultrasound procedure time, so a lot of concerns and from the team, nursing team, was about touch time and how long it would take if we were doing this, and would the baby get cold, etc. We've thought a lot about that, and the actual time it takes, because of the way that we run our ultrasound on the babies, is 2 to 7 minutes. Our average is 3.5 minutes. I know it's not a lot of babies, but it's quick. It's not a long time that we have the ultrasound probe on. If you could have a look. This is just to say I looked at the other babies in this 6 months just to make sure it wasn't that the team are really good at putting in UVCs, or it was luck of the babies. And in the other babies, it was 36, sorry, that weren't done under ultrasound guidance, our success rate in those babies was 38%, of which they, almost half of them also needed further adjusting as well. Again, low numbers, but it's just to prove that what we're doing is working. Some extra successes. I don't know if that video will play, Liam, if you press go, but I wasn't sure whether this would be very technically and practically complicated in small babies because of just number of hands, and we are very we do a lot of talking around the communication that's needed when we do this as a team. And we've had success in our premature babies, the smallest being 380 grams. And then, as I said before, we've had success. We've had 2 now that have been out of region that we've managed to replace and put into the correct position. Liam, if you go next slide. I think that's just a summary again, that we've got less touch time, quicker TPN, increased success, and less x-rays, with more education for the team and a focus on safety. I think that was just a video to show one going in because I'm obsessed by them. I keep taking lots and lots of clips, and I think this was a repeat one. The baby was actually 2 days old, and then you can see it sliding into position at the end there. So a big focus now that I've got, so I'm 6 months in, I've got 6 months to go, is just about sustaining this. I don't want to go and it not continue, although I'm going to the transport team, so I can continue to come and support. But we've been working on our guidelines, our modules, our face-to-face training. I've now got, of the current team, 7 registrars who have all done well, they haven't all done the module because the module's just gone live, but they've all seen the module. They've had face-to-face training, educational meetings, and they've all attempted at least one with me present. I've got the lead ANMP. We are talking about, and I'll bring it to Liam, the emergency POCUS WhatsApp, and who might be okay to do and be involved in that. I will come whenever and manipulate my hours outside of probably when I'm sleeping or got childcare. But of course, most UVCs come in the night, which is why I've only managed to get 35% of the last 6 months under ultrasound guidance. But we are trying to increase that success. And then just for time, I'll probably stop there, but there's lots of stuff that we've been doing on lungs as well and other projects that we're looking at. But yeah, Liam, I'll pass back over to you just to finish off. You're muted, Liam.
I was going to end it there anyway. I think I'll end it there just because I'm conscious of time as well. But yeah, thanks very much, Sarah. That was great. And thanks very much for your time. Yeah, I suppose now's the time if anyone wants to ask us any questions.
Thanks, Liam. Can you hear me? Yeah, thanks, Liam and Sarah. Excellent. Yeah, sorry for my earlier technical issues with my mic and speaker. Thank you. That was really brilliant. Nice to hear your work on POCUS Fellowship, and amazing, like, what you guys have done. And also nice to hear about your governance structure as well. Excellent. Does anyone has any questions? If you have any questions, either you can put on the chat box or you can raise your hand and you can ask the question.
If no one else can hear me.
Hi, Sarah. Yeah, hello. If you can just introduce yourself and if you can ask the question, that will be great.
So I'm another Sarah, and I actually do almost the exact same as you in Oxford, and I've been told I need to get in touch with you to work out, because I heard about the wonderful things you're doing with your program, and you're sort of, in that sense, you've moved ahead of us, and the training aspect. I'm still trying to work out how you create a program that's accredited, that's safe. We've had a guideline for several years. I work as a full-time, 50%, just doing POCUS on the unit here now. So cardiac lines, and I've been developing it. I do a lot of migration, so sort of monitoring. So 3 days a week I'm in. That's the next stage, I suppose, and it's a good training opportunity too. So I suppose my question was sort of, have you sort of incorporated the concept of then monitoring these lines? For example, I've seen a line which was focused on insertion today, and then today's day 3, I've gone in, that line is no longer in a good place. But you wouldn't see that if you don't do your scan at day 3 or day 5, and we see quite a lot of migration. So is that part of your policy? Because I think that's something which I've definitely sort of, on my practice, found a huge problem with that.
It's not part of our practice, actually, Sandra. Sarah, sorry, it's a really good point. I think we're probably more conscious of of lines in the upper extremities, because we've probably had a few more complications from that actually, I think probably, and this is anecdotal, I don't have evidence behind it, is that people ultrasound lines in the upper extremity, but that's dependent. I certainly think upper extremity ultrasounds of PICC lines is a much more difficult skill to teach. I think the UVCs, I think it would be something that we'd want to do. I think at the moment we want to just get, again, that critical mass of people who are used to putting it in, and then get really good at that. It's one of the things that I took from the Iowa people when I've listened to them talking about micro preemies, is like, get really good at something, prove that you're really good at that, and move on to the next bit. And the next bit will naturally be about looking, hopefully for UVCs, about migration. One of the things that I should say is that whilst we use ultrasound to put in these lines, we've had a number of years ago, pre Sarah and I's time, we had a mandate handed down by the coroner that our final X-rays, our final line position, needed to be seen on X-rays. So one thing I should say, that this is great that we're doing all this line ultrasound stuff, but we do have to get an X-ray to prove the final position. I
was going to ask whether you're still doing that, because we've actually we have 2 people who we are confident and agree on position. We don't always do a line position at that time. X-ray will do it at some point when they're doing whole package along.
If we're the final line position is going to be an X-ray, it's something that we need to think about, Sarah. It's not something that we do as a standard at the moment.
I think just to add on to that though, Liam, just a second, like we have had babies where we have put them under ultrasound and then somebody the next day has done an X-ray and have asked us, you know, but it was actually the baby where we'd put the line back in. You know, they think it's moved when the radiologist did the scan, but what they were seeing was the artifact of the previous line, and we got an X-ray to prove it was still in the right position. And then when we scanned it, because we were the team that put it in, we saw it was still in the same position, the artifact they were seeing. So yeah, and I think Liam, you have done a couple of scans just to check as well, but we still use X-ray, as Liam was saying.
Okay, we'll go to the next person. Shall we go to Akolisa now first? Do you want to?
Hi, good afternoon, everyone. I'm Akolisa. I'm one of the neonatal consultants from Royal Preston Hospital in the Northwest. Again, I'm going to say congratulations to Liam, Sarah, and your team. I think for us in Preston, we have started to do some of the long ultrasound. We do the cardiac and the head scans and the lines, but I think the long one is the one that we're kind of learning at the moment. And it was interesting for me to actually listen to how you've set up the processes, and just like you mentioned, your governance systems as well. I think at the moment we have just got a guideline which has been reviewed, and we're trying to get training. I'm learning it as well, to get training on board for some of the senior medical and members of the staff, i.e. the consultants, really. I'm interested for one question. We've got a baby almost similar to the very first one that Liam presented, a preterm baby with a patch in the right side, which we've been ultrasounding like you have done. We think it's probably a sequestration ourselves as well. I'm interested. Why did you do a CT scan that earlier on? And what's the outcome for that baby? Because our baby now was born at 24, 25 weeks. It's about 30 weeks now on dual PAP. So I'm just interested to see what the outcome for your baby was actually subsequently.
Yeah, so so we did the ultrasound. Me and Sarah actually, I will say it was in the middle of the night, and we ultrasounded this baby, and we both said this is an extra lobar sequestration. The CT scan was done when we proved where the feeding vessel was on ultrasound. I think it was the surgeons. They needed it to know exactly where the feeding vessel was, to know because I could see that big one, but I didn't know if there was collateral vessels. So I think they needed the CT scan purely to know how many feeding vessels there were into that massive sequestration. That baby had a really uneventful surgery. The surgeon said that it was, as surgery goes, quite easy. They clipped those two big vessels. They waited 5 or so minutes to see if the baby was okay. Baby was fine. And they cut out the mass, and it basically fell out because it was an extra lobar sequestration. The baby itself needed quite a lot. It was 30 weeks when they were born. Needed quite a lot of high frequency, high pressures. So actually, they've just gone back to their base hospital now. They're term corrected on some high flow at the moment, but they're doing well. Actually, they're doing well. And the sequestrations. I mean, this was so big that it wasn't going to regress. I think some, depending on the size, can regress over time. But this also, we were worried that this, because of the feeding vessel being so big, that it could also have a bit of a steal effect. But it didn't really. The baby actually, from a cardiovascular point of view, remained quite stable. We got a CT because I think, one, to get the definitive diagnosis, because again, on ultrasound, when I was looking for it in the literature, there wasn't much in the literature about lung sequestration, lung ultrasound. There was a lot antenatally because of the fetal medicine kind of stuff, but not the postnatal stuff. So we're hoping to get this case report out somewhere for this particular baby. But that's why we got the CT scan.
Thank you.
I can see there was a question actually, Harshish. Do you want me to answer the question in the chat?
Yes, please. Yeah, there are a couple of questions on the chat. Yeah.
So Akin, really interesting. Isolated unit. So this would be amazing for isolated units and those DGHs without paediatric radiology support. How can this be rolled out to units with less acuity? I suppose the thing, Akin, is it could be rolled out. You just need to make sure that, I suppose the difficulty, if you don't have much acuity and much need to do it, is you need to get well versed in doing it and practiced in order to keep your CPD and keep your skills up. I think a lot of the accreditation programs, the accreditation program that exists at the moment, which is Cactus, does require you to do a certain amount of scans after you've accredited. I can't remember what that is, but I imagine that will be part of hopefully the NeoFOCUS kind of the focus with the accreditation that eventually comes out there. And I suppose if you are an isolated unit that has more acuity, then you're going to be doing the skill relatively frequently. But I suppose the one thing that's really helped with us is having the weekly meetings. So even if you don't have a scan to present, you're part of a meeting regionally, which we found works really well, because our units are geographically, whilst we might look close, the transport links are rubbish. So actually us travelling to Cornwall to attend these meetings isn't good, but Teams and the way that that's evolved out of COVID and things like that has actually worked really well in order to support the continued learning that we have from that. I don't know where you are, Akin, but whether you have something similar, that might be something that you could look into. More than happy to be contacted about this as well.
Thank you. Yeah, I'm actually based on the Isle of Wight, which is as remote as it gets in the UK.
Oh, wow. Okay. I don't know. Well, Southampton, because Michael Gakauskas, who's a PICU consultant, is head of Cactus. So there might be something similar there that you could engage in. But then hopefully when NeoFOCUS, when that comes about, then that's something that you can look into. But that would be something that we use.
Thank you. Thank you.
Liam, there's one more question. I think Sarah has answered that question. Do you still perform X-rays to check the position of the lines inserted under ultrasound guidance? Yeah, and that's because it was there's a case from a decade or so ago where we had a prevention of future harm order from our local coroner about a completely different case, but ultrasound was used in that child in isolation without an X-ray. So we've had that. So that's partly, and it's partly medical legal. It's partly because we've had that practice, but also I suppose it's at the moment. Do we have a gold standard? I mean, I would argue that seeing something in real time probably would be, but then that's operator dependent. So anyway, so you can argue it either way at the moment. I kind of feel, but it's what we do. I think now, as per BAPM recommendation, we have to do, as more evidence come and more training and more people feel more confident, maybe if someone is doing POCUS is very confident, then probably they may get away from X-rays. But at this point, yes, we still have to do X-rays. If there's no other question, I have a question to Sarah regarding this UVC POCUS. We are doing very similar to that in West Midlands. We have 5 NICUs and 5 NICUs. We're doing this POCUS and teaching and training. But unfortunately, we did some interim data analysis. We not have much success rate. We're slightly better with compared to retrospective data using radiology. But what interesting is you said 90% of the POCUS of the UVCs were done by yourself, right? That's what you mentioned. Is it because of that you're seeing more success in getting the UVC in correct placement? Because in the 5 NICUs we're doing, we have slightly marginally improvement, but not like a significant improvement with UVC POCUS.
Yeah, I mean, it's very small numbers that we've done, and so I don't expect to continue to have a 86% success. I'm sure it will drop. I think it is probably because I am getting myself more and more skilled, and I think partly it's around the education that I have done for myself and the package that I have built and the way I have started to understand the ultrasound images. As I train others, I focus a lot on them understanding the anatomy that they are looking at before even trying to get to the point in which they're pushing the lines. Well, they're not pushing, but they're imaging the lines. I have sort of evolved, we reflect on each case as well as a team, and I think our reflections of when they've been successful have been the way in which we've essentially straightened up the vessels and the lines, and some of them, they really are Z-shaped, and you initially they keep curving round into the portal veins, as I'm sure you've experienced too, and it's just about how we manipulate and put pressure. And I think probably we're successful because I have done most of them, but my focus is all about trying to share that learning that I have had. I've come from a little bit of skill from beforehand and do cranial ultrasounds and stuff, but I'm no expert. I'm no anybody could do it. It's just volume, isn't it? And so I think as we train more people, the key thing for me for training is the reflection on learning of what I have learned in these small bits of how to adjust and how to line it all up. And then it's making sure that they fully understand the anatomy of what they're seeing. And yeah, I don't expect that we will continue such a high success rate, but I hope that we will do better than 50% based on what we see under ultrasound. Yeah, I think my colleagues, hopefully everything will continue smoothly and will continue. That 90% would be lovely, actually, but I don't expect
Excellent.
that
I
to
think
happen.
yeah, doing multiple times has definitely helped
Yeah,
you,
yeah.
and you need to have more success rate. I have one more question before we go to Mona. You said, like, you have a governance structure and you guys review all the images once in 2 weeks. Who all involved in these review meetings? Is it only POCUS team or all the consultants or radiologists? Just if you can.
So it's not radiology. So it's particularly led by Liam or myself, and then it's the team that happen to be on the unit and everybody that we can bring in. If people have perhaps done the line or have done a lung ultrasound that are at home and want to join, they can. They don't have to out of hours, of course, but they will. A couple of consultants will come. We are trying to build this still as a program and to show its usefulness. But I also send out educational monthly letters about how we're doing. And we also go to our audit meetings and stuff like that. So at the moment, it's more an educational platform for those that are doing it to sort of keep the talk and the relevance there. But it's not necessarily a structured review meeting like you might have for x-rays with radiology. I don't know if Liam wants to add any more to that.
Liam says his computer is sending some restart message.
Yeah, so I was going to say it's saying 29 seconds. So
Okay.
29 seconds to answer. I don't have much more to add from what Sarah is saying. I think part of it's going to be very dependent on what, it's going to be very much focused on. I think we very much wanted to build a structured in Sarah where it was reliance on us, because whilst our radiology colleagues are great, they're swamped at the moment, and so actually adding another meeting to that, if we could try and be autonomous to it and have a governance structure that meant that the training was robust, we felt that might be good enough. Right, I've gone down to 0 now, so I might.
Okay, Liam has disappeared. Okay,
should
we go to next question? So I'm happy to take the next question from
Mona.
I'll
see if I can. Yeah, absolutely.
Okay, Mona, do you want to go, please?
Oh, yeah. Hi guys. I would like to congratulate you guys on this great work for what you have started. My question is about the practicality actually of having a fellow, POCUS fellow. If you could tell us, Sarah, what do you do every day, for example? How is your rota scheduled? And if you're in the unit, are you doing scans all the time, for example? Your time on the unit is doing either focusing lungs or lines and how, because we are thinking about the same, but we would like to, for example, to plan it and how it will work.
Yeah, so 60% of my time is clinical, so I cover the unit. It's ITU loaded, so I do some HDU and postnatal cover, but I predominantly do long days on ITU or nights when I'm clinically on, and that is helpful from a POCUS point of view, because the fact that I do more ITU long days and nights, and there's lines and scans for lungs to do, then I am most of my time is in the unit and where I need to be to do that. For the other 20% of my time, I just get project time, and that essentially works out to 1 day a week, but it might be loaded in the month. I might have a couple of days 1 week, and then a week where I'm on nights, and then one day the next, and the rest of it. But because I am relatively flexible in the rest of my life, as in I have some childcare, I will move those shifts about so that I try and spread myself evenly. So if somebody says to me, we've got a baby that's definitely coming tomorrow who's going to need lines, can you come? I will come in, and then I will adjust my time back in other ways. when I am around on those days, there might not be anybody who needs a lung ultrasound or a line ultrasound. And in the background, I then spend most of my time, it's been a huge amount of work doing all the governance stuff and building the educational program, or we run educational meetings. And I'm now very much at the point where when I am here, I'm teaching others to do it rather than doing it my actual self as well. So one of the biggest problems we do have is, though, that there is, Liam, there's a few consultants who are very happy to do it and know it particularly how to do the line insertions, but there is just me who's, we're getting further. We've got more registrars who now know, but I can't cover all of the nights and all of the weekends. So trying to work out when these lines are coming and getting them done, it has been one of our difficulties, but I'm just trying to focus on training more and more people in a very in as safer way as we can. Does that answer, Mona? I don't know if you want any more specifics about my work schedule, we can send it through, I'm sure.
Yeah, so it's just to understand it. So you're 60% clinical, where you're doing either a long day or normal working day, and 20% for your QI project and teaching, and the other, so you're 80%.
I'm 80%, yes, sorry. My other
okay.
20%, I'm with my children on a Monday.
Okay, all right, that's fine. So you don't have a very dedicated time, because I witnessed hemodynamic trainees where they don't do commitments, they don't do clinical work during the day apart from on calls, where they are either in the echo lab learning how to perform echo, or performing echoes on babies who need echoes on the unit. So it's probably a bit different here. So if you're clinical, you are performing POCUS as well. Am I right?
Yeah, if I'm clinical and somebody needs ultrasounds, then I will do it and will just make that work, because most of my clinical, I'm in ITU and I'm the registrar, so I'm predominantly, we do often run 2 registrars, but I'm predominantly the senior registrar leading it as well, so I will be there to help. And this project is teed up for the fact that when I'm clinical, it still works. If somebody else is doing other research stuff, they might not have the time to do as much, because you're right, 20% time is not a huge amount of time. I'm different to a hemodynamics fellow, where they need to spend a lot of time in echo lab. I think lung and line ultrasound, as you probably aware, is a lot less complicated, and I'm doing accreditation through Cactus where I can to get that training, and I have a lot of support from Liam and Katie as well. But yeah, when I am clinical, I am covering neonatal service. I'm not just doing POCUS.
Great, thank you very much. Thanks.
Yeah, no problem.
Hi. Thanks, Mona. Thanks, Ava. I can see Liam is back on his phone, I guess. Fine. If there are no other questions, I think we'll make a close for the meeting, because I already overrun by a few minutes. Fine. Thank you, Liam. Thank you, Sarah. Thank you very much for sharing your experience of POCUS Fellowship program. Really nice to hear. I think there are very few POCUS Fellowship program in the country. I don't know, maybe there's one in London, I guess, St. George's. Apart from that, I've not heard any POCUS Fellowship program. So it's nice. I hope more and more units implement POCUS Fellowship across UK, and there'll be more POCUS training happens, which is very essential for neonatal trainees. Excellent. And those who don't know, NeoFOCUS have advertised POCUS, line POCUS and lung POCUS framework. They're recruiting trainees and consultants. So if you're interested, please apply. It will be good to develop some a framework for practice, so that everyone have the uniform practice throughout the country. Thank you very much. Thanks everyone for joining. Brilliant. Have a nice rest of the day and have a nice weekend. Bye-bye.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.